Thank you to the meeting organizers for the opportunity to present this case. These are my disclosures not relevant to the contents of this talk. This is an 81-year-old Caucasian male who presented with bilateral blurriness and dimness for a year. He had multiple vasculopathies and a possible history of a non-arteritic ischemic optic neuropathy in the left eye. His medications interestingly included amiodarone, although he states that his symptoms started before taking this medication. You can see that his vision is decreased in both eyes. His pupils had no APD. He had bilateral central scotomas and an infranasal defect in the left eye. His color vision was slightly diminished. You can see here on fundus photos of the optic nerves, there's a dense vitreous condensation overlying both optic nerves. Additionally, in the left eye, there's an area of sectoral pallor and peripapillary hemorrhages. The OCT line scan really defines how profound of a tractional force the hyaloid is having over the optic nerve head, particularly on the right eye. And this is corroborated by the fluorescein angiogram, which reveals bilateral optic nerve head leakage. Interestingly, he also had an area infratemporally in the periphery of his right eye with a shallow retinoschisis and no inner or outer wall holes. You can see the pooling in the cystoid cavities on the FA. Here are his initial 24-2 Humphrey visual fields. So I diagnosed him with vitreopapillary traction, causing an optic neuropathy in both eyes and possibly also contributing to retinoschisis in the right eye. Planned for bilateral sequential pars plana vitrectomy with hyaloid elevation. Here's just a little clip from his right eye surgery. It was very adherent to the optic nerve. I had to put the vacuum on maximum. You can see it pop off of the nerve head. And then here I am peeling very gently over the area of retinoschisis so as to not cause any iatrogenic breaks in the thin inner wall. I've followed him for over a year now. He's done well post-operatively with visual improvement to 20/30 in his right eye from his preoperative vision of 20/60. His left eye has more or less remained stable, although his visual fields have improved, as you'll see shortly. Here's the sequence post-operatively of his OCTs. And his fluorescein angiography also normalized, although interestingly, both eyes went through a transient phase where there was increased leakage over the optic nerve head. His retinoschisis cavity completely collapsed. And here's his post-operative course of 24-2 in his right eye, and also his left eye. And you can see there the persistent inferior hemifield defect, likely related to his previous history of NAION. So I thought this case was interesting because I think this probably happens a lot more than we recognize, because most cases of VPT are probably transient and self-resolving, but something to keep in the back of your mind if you ever see a patient with a similar presentation, because there's actually something we can do to reverse it. Thank you.
Thank you, Christina. Very interesting. So it has been shown by Heider many years ago that PVD is less frequent in cases with NAION, so we can speculate about tractional forces. So you think we should think about a very, very dedicated OCT of the papilla in these patients? In every case, we diagnose NAION.
I think if there's reason to suggest that tractional forces might play a role, it's definitely reasonable to consider, especially since it's so easy and quick to obtain an OCT these days. It's probably something that our neuro-ophthalmology colleagues don't think about all that often, and I think that's really where that sort of education amongst the fields can be helpful before they come to you.